Good afternoon, everyone. We will start with the rest part of the topic, that is hematinics. So, hematinics are the drugs which are used in treatment of anemia. So, the first drug we have considered in detail is the iron. Now, the second drug of it, that is the folic acid, and the third drug, that is the vitamin B12 or the cyanocobalamin, we are going to study in detail today. Okay, and with this we will finish with this particular topic, and the next topic that we are going to start from next lecture is the coagulants and the anticoagulants. Okay, so let's see, this all we have covered till now. So let's move to the slide. Okay, folic acid. Okay, so the folic acid, also known as steroid glutamic acid, it belongs to the B complex group of vitamins, and its deficiency causes, very important, megaloblastic anemia. Okay, so we have already studied about the megaloblastic anemia, so I won't go into those details of the pathophysiology of the megaloblastic anemia. We will only focus on the therapy part of it. Okay, so around 50 to 100 microgram per day folic is required by a healthy adult, and about 200 to 400 microgram per day is required in pregnancy and lactation. Okay, so during pregnancy and lactation, the requirement of the folic acid, it increases around 4 to 5 times. Okay, so it is used in the treatment of macrocytic hyperchromic anemia. Okay, so macro means big, the cell size is big, that's why the type of anemia is megaloblastic. And hyperchromic means, hyper means excess, chromic means chroma, means color. Okay, so there is a excessive red coloration of these cells, and the cell size is also greater. So we are basically talking about the red blood cells over here. Okay, so the sources from which natural sources we get the folic acid, that is from yeast, green vegetables and liver. These are the rich sources of folic acid. Okay, so liver of animals. Okay, so livestock animals we are talking about, from their livers we get the folic acid. Why? The reason is quite clear, because the liver acts as the storage unit for the folic acid. Okay, so the body stores of folic acid, they are low, and thus stopping the intake of folic acid, these stores deplete, anemia develops within 1 to 6 months. Okay, so it means that the folic acid consumption should be adequate, as it is not stored in the body for the long time, and as it is not stored in the body for the long time, its stores, they will get depleted if we don't consume enough amount of folic acid through our daily intake. Okay, so mechanism of action: folic acid is inactive biochemical compound which changes to tetrahydrofolic acid and methyl tetrahydrofolate in the presence of dihydrofolate reductase enzyme. Okay, so folic acid as such is inactive, but its active forms are tetrahydrofolic acid and the methyl tetrahydrofolate. And what causes this conversion? It is the enzyme, that is dihydrofolate reductase enzyme. Okay, so these folic acid congeners, they are transported across the cells through receptor mediated endocytosis. Okay, for the regulation of erythropoiesis, synthesis of purine and thymidylate nucleic acids, then interconversion of amino acids, then methylate the tRNA, and the generation of format. Okay, so what different functions are being played by this tetrahydrofolic acid and the methyl tetrahydrofolate is that first function it plays to regulate the erythropoiesis. When we talk about this regulation of erythropoiesis, we are basically concerned with the anemia. Okay, so in anemia, this erythropoiesis is itself deficient or it itself abnormal. So any deficiency of the folic acid will be affecting this erythropoiesis process. Okay, so second process which is not concerned directly with the this anemia, but it is also important that it helps in the synthesis of purine and the thymidylate nucleic acids, and next is it also causes interconversion of amino acids. Then it also leads to or it also facilitates the methylation of the tRNA, and also it helps in generation of the format. Okay, so the folic acid it can regulate high homocysteine levels by remethylation of the homocysteine to methionine in presence of methionine synthetase enzyme and using vitamin B12 as a cofactor. So apart from all of these function, it also can convert homocysteine into methionine in presence of a certain enzyme, that is methionine synthetase, and using vitamin B12 as a cofactor. What is this cofactor? It means that for the effective functioning of this methionine synthetase, it requires vitamin B12. Okay, so if vitamin B12 is not present, then it becomes very difficult or it becomes impossible to convert the homocysteine into the methionine, or the reaction will take place that will convert homocysteine to methionine, but the reaction will be very slow. Okay, so on this only, on the mechanism of action of the folic acid only, we will see one video which I have sourced from the YouTube. Okay, so this is the one.
Hi everyone, in this video we're going to talk about folic acid, which is vitamin B9. Folic acid came from the name folium. Folium means leaf of vegetables, and we would know that leafy vegetables are the key source of this vitamin. Let's talk about the chemistry of folic acid for a bit more details. So folic acid has three different chemical residues. First, the benzene ring, then a benzoic acid moiety or parabenzoic acid moiety, and at the last there is glutamic acid residue. So this is the overall structure or the chemical structure of the folic acid. Now the folic acid or the folate is always associated with several residues of glutamate, because in this format they are more soluble, and all the natural sources of folic acid include leafy vegetables, some grainy vegetables, etc. Now folic acid is absorbed in the jejunum of the intestine, but folic acid in its glutamate bound, polyglutamate bound form cannot be absorbed. So polyglutamate form has to be chopped off in order to be absorbed properly in the intestine. The monoglutamate form would be ready to absorb. Now once it is absorbed in the intestinal lumen by the intestinal epithelia, it is then converted to tetrahydrofolate by THF reductase. Otherwise, sometimes this folic acid, once absorbed, is transported to the liver, conjugated with globin and vitamin E. Later in the liver, the folate or the folic acid is converted to dihydrofolate and tetrahydrofolate sequentially, and reductase enzymes with the help of NADPH carry out this kind of reactions. Let me tell you that folic acid folate is an important metabolite or important compound that helps in thymidine synthesis, DNA methylation, DNA synthesis, and many more. Especially one carbon reactions are triggered by folate or the derivatives of folate. That is why folate is so important in terms of biochemical function of the body. Now let's talk about what are the manifestations of folate deficiency. Starting from development, our neural tube closes and thereby our brain starts developing. But if we have deficiencies in folate, the anterior portion of the neural tube might not fold, lead to anencephaly. That means the baby is born without a cerebral cortex or without a telencephalon, and eventually it dies. And if the posterior part of the neural tube does not close properly, it leads to disease like spinal bifida. That is why it is recommended to have 400 microgram folic acid daily during pregnancy, and the necessity and the demand of folic acid increase during pregnancy. Folic acid has also a role in terms of erythrocyte development. Because let's look at how erythrocyte develops. Inside the bone marrow, there are hematopoietic pluripotent stem cells. From there, in a sequential step, erythroblast is produced and that differentiates into erythrocyte. In case of folic acid deficiency or folate deficiency, hematopoietic stem cells give rise to macrocytes, which are immature version of these RBC and look pretty much spherical instead of that characteristic dumbbell shape. Now these macrocytes are useless. Mostly they are degraded in the spleen. Just to compensate that, the hematopoietic pluripotent stem cells differentiates into megaloblasts. Or these megaloblasts are immature versions of these RBC and pretty much useless. Now, other than that, hematopoietic pluripotent stem cells also give rise to myeloid progenitors, which can give rise to neutrophils. But in case of folic acid deficiency, there are hypersegmented neutrophils which are produced, and it's a key characteristic of folic acid deficiency. Then question is, how can folic acid deficiency or B9 deficiency can occur? It can occur due to lack of leafy greens in your diet. It can also occur due to lack of absorption or a problem in the absorption process in the jejunum. And this lack of absorption can be due to over-alcoholism or many medicines that you are taking. Now, let's see the visible symptoms or visible biomarkers of folate deficiency. First thing which is affected are the mucosa. For example, the mucosa in your tongue or in your lips. So many times you have seen you have bitten your tongue accidentally, but it heals in 1 or 2 days. Pretty rapid, right? But when there is folate deficiency, this healing process is delayed, and you can see blemishes inside your lips or inside your tongue. This might be one visible symptom of folate deficiency, and this persists for a long time. This is out of these kind of actus ulcers are one of the reasons or one of the consequences of folate deficiency, not exclusive. Now the question is how we can detect folate deficiency. What are the tests or what are the available diagnostic measures we have? We know that folate derivative, tetrahydrofolate, is very important for homocysteine conversion to methionine. So homocysteine gets converted to methionine with the help of methyl THF, and that is how the methyl THF donates its methyl group. So it's a 1 carbon metabolism that is going on. We'll be talking about 1 carbon metabolism later in details, but ultimately it produces THF. But when there is a deficiency in folate, as we can understand, that methyl THF won't be available. As a result, homocysteine won't be converted to methionine. And when homocysteine is not getting converted to methionine, homocysteine level increases in the blood, and as a result, it could be also excreted in the urine and forming the situation called homocystinuria. So, detecting homocysteine in the urine is one of the key diagnostic measures of this folate deficiency. Other than this, peripheral blood smear test can also detect the deficiency of vitamin C9 because we would have megaloblastic macrocytic anemia in case of folate deficiency. In the peripheral blood smear test, we can at least visualize the hypersegmented neutrophil and the large and oval roundish RBCs, which are bigger than the normal RBCs. This is how the folate deficiencies can be determined. I hope this video was useful. If you like this video, give it a thumbs up. Don't forget to like, share, and subscribe. Thank you.
Okay, so that particular video must have cleared most of your doubts regarding the various rules of folic acid in our body and what are the signs and symptoms of the folic acid deficiency in the body, as well as how to detect that particular folic acid deficiency. Okay, so moving forward to the pharmacokinetics of the folic acid. So the polyglutamate form of this 5CH3H4 folate, that is the dietary folate, is hydrolyzed by alpha glutamyl transferase enzyme, which is present in the brush border of the intestinal mucosa. Okay, so oxidation of active H4 folate is prevented by the ascorbic acid. Okay, so monoglutamate form of the 5CH3H4 folate is absorbed, as you can reckon it from the video. Polyglutamate form is not absorbed, but the monoglutamate form is absorbed and is thus transported while being bound to the folate binding plasma protein. Okay, so it is stored in the liver, like 5 to 20 milligrams of it, and in some other tissues as polyglutamates. Okay, so folic acid experiences enterohepatic circulation and is excreted through urine and stool in trace amounts. Okay, so therapeutic uses of the folic acid, it is mainly used in treatment of the megaloblastic anemia, which is occurring due to folate deficiency. Okay, other than this, it is also used to cure the first nutritional megaloblastic anemia, megaloblastic anemia of pregnancy, megaloblastic anemia in infancy and childhood, megaloblastic anemia which is associated with alcoholism and liver disease, then chronic hemolytic states, then megaloblastic anemia of the malignant diseases, then some cases of the agranulocytosis. Okay, so the adverse effect which are observed with the folic acid use in case of deficiency, they are very rare in injectable and oral preparations. So the large doses of the folic acid, they may counteract anti-epileptic effect of the phenytoin and the phenobarbital. So fits may occur in controlled patient. So although the adverse effects are rare, but if a person who is suffering from the epilepsy disease, if he is taking this folic acid along with the drugs which are prescribed for the treatment of epilepsy like the phenytoin and phenobarbital, then there is a possibility of that person will suffer from the fits, that is the epileptic seizures will occur, because this large doses of folic acid, it inhibits or it causes a decrease in absorption of this phenytoin and phenobarbital, and thus their plasma concentration reduces, and thus they are not effective as anti-seizure drugs in case of controlled patients. Okay, so next, preparation and dosage. It is formulated in form of tablets, either alone or with other vitamins. Okay, so tablets have 0.1, 0.4, 0.8 or 1 milligram of pteroglutamic acid. So the folic acid injection, they are formulated in aqueous solution of sodium salt of pteroglutamic acid. Intramuscular injections of leucovorin calcium are also commercially available. So next is the vitamin B12, that is the cyanocobalamin. So a wide range of both natural and semi-synthetic compounds are grouped in cobalamins family, which include cyanocobalamin, that is vitamin B12, and the hydroxycobalamin, which is vitamin B12A. Okay, so various other cobalamins are present, but they are not as beneficial as vitamin B12 and are also less stable. So vitamin B12 is primarily used in treatment of pernicious anemia. This is very important. Okay, so sources of the vitamin B12, they like it is one of the most important vitamins, and in humans it is formed by colonic bacteria. That means the bacteria that reside in the large intestine, but it is not absorbed. This is very important. Although it is produced by colonic bacteria, but it is not absorbed, and it is thus excreted through the feces. So thus dietary intake of the vitamin B12 is essential. Okay, so in food, the cobalamins are found bounded with the proteins, and before absorption, this bond is broken by the process, that is proteolysis. Okay, so around zero point 0.6 to 1.2 micrograms per day of vitamin B12 is required and is mainly stored in the liver. Okay, just like that of the folic acid, it is stored in the liver. So total vitamin B12 stored in the adults is around 5 milligrams. So it is naturally found in animal products, which include fish, meat, poultry, eggs, milk and milk products. Okay, so mechanism of action in body, the vitamin B12 is used in following two forms. That is, the first form is the methylcobalamin and the second form is the 5-deoxyadenosine cobalamin. Okay, so let's see about the methylcobalamin first and then 5-deoxyadenosine cobalamin. So methylcobalamin, this form of vitamin B12 is used as cofactor by the methionine synthase enzyme, which is involved in conversion of homocysteine into methionine. So this reaction we have already seen, which is actually facilitated by the folic acid congeners. Okay, so in tissues, the vitamin B12, it changes to coenzyme B12, that is methylcobalamin, which is needed for conversion of methyl malonate to succinate and for synthesis of methionine from the homocysteine. Okay, so again the same thing, that is conversion of homocysteine into methionine, and also this helps in conversion of methyl malonate to the succinate. Okay, so vitamin B12 also regulates sulfhydryl groups in the reduced form, which is required by various sulfhydryl activated enzyme systems. Okay, so now it becomes your duty to find out that what is the function of this succinate and this which are these various self-hydryl activated enzyme systems. Okay, so just try to find out that. Okay, you have to refer the biochemistry book for it. You will get details of it over there. Okay, what function this succinate plays, what function this methionine plays, what function this SH activated enzyme systems plays. Okay, just try to find out. Okay, so that you will be able to correlate the functions of the methylcobalamin with the various body functions. Okay, so next is the 5-deoxy adenosine cobalamin. So it acts as cofactor for the L-methyl malonyl coenzyme A mutase enzyme, which changes L-methyl malonyl coenzyme A to succinyl coenzyme A. So you must have heard about this succinyl coenzyme A. Okay, so this conversion is essential for extraction of energy from the proteins and the fats. So the succinyl coenzyme A, which gets formed in presence of the 5-deoxyadenosylcobalamin, is also required for the production of the hemoglobin. If you remember the synthesis of hemoglobin, then succinyl coenzyme A was the part of it, or it is one of the raw material which is required for the production of hemoglobin. Okay, so the pharmacokinetics of the vitamin B12 in food, we will find the vitamin B12 as the protein conjugates. Okay, so the free vitamin B12 is released in the stomach and duodenum by gastric acid and the proteolytic enzymes. Okay, so it is also released by cooking food. Intrinsic factor, which is secreted by the parietal cells of the stomach, is required for the absorption of the vitamin B12. So this intrinsic factor, it complexes with the vitamin B12, which is the extrinsic factor. Why it is called as extrinsic factor? Because it comes from outside. Okay, and as this intrinsic factor, it is secreted by the parietal cell, that's why as it comes from inside, that's why it is called as an intrinsic factor. Okay, so this once the complexation occurs between intrinsic factor and extrinsic factor, it gets absorbed in the distal ileum. So distal ileum is the site of absorption for the this particular vitamin B12 through highly specific receptor mediated transport mechanism. Okay, please remember where exactly in the body or in the gastrointestinal tract this iron, then vitamin B12 and the folic acid, they get absorbed. Okay, this is very important. You, whenever you are writing the answer in examination, it must come in your answer sheets. Okay, so but if high doses, that is 1 milligram of vitamin B12 are given orally, little amount is absorbed by diffusion even if the intrinsic factor is absent. Okay, so this is very important. In certain cases, the intrinsic factor is absent. So, like in case of pernicious anemia. Okay, so pernicious anemia, it happens due to destruction of these gastric parietal cells by autoimmune mechanisms, and because of which there is a deficiency of the intrinsic factor, and thus there is deficiency of the vitamin B12 absorption. So in this case, we have to give high doses of the vitamin B12 so that in absence of the intrinsic factor also some of it will be absorbed, and it will help to negate the deficiency of vitamin B12 that has been created. Okay, so continuing with the pharmacokinetics of it, it gets combined with the transcobalamin, which is a specified plasma globulin, and is thus transported into the blood. Okay, so the liver, that is hepatic, stores around 3 to 5 milligrams. It stores surplus vitamin B12. It is written surplus. That means if there is any excess of vitamin B12 which comes through our food sources, that is stored in the liver, and this hepatic store, it lasts for 5 years. Okay, so understand this thing very clearly. Unlike that of the iron deficiency anemia or the folic acid deficiency anemia, which can result in like acute conditions, but to develop the vitamin B12 deficiency anemia, it will take very long time. How much long? It is around 5 years, because the liver, it stores the that particular vitamin B12, and those stores are sufficient to sustain 5 years of vitamin B12 deficiency or requirements. Okay, so if due to any reason the absorption of intestinal vitamin B12 is stopped, so the liver can supply the vitamin B12 for next 5 years. Okay, so the deficiency anemia, it occurs only when hepatic stores of vitamin B12 also gets exhausted, which is very less likely. The reason is that uh, if there is problem with the parietal cells, then it will be immediately reflected, or it will immediately produce the signs and symptoms. But uh, this vitamin B12 deficiency, it will hardly be created as whatever food we eat, it contains sufficient amount of vitamin B12. Vitamin B12, it happens in the people who are strict vegan. Okay, strict vegan means what? They even don't have the milk and milk products because they think that it is non-vegetarian. Okay, so if you have heard about the recent PETA application, you must correlate with whatever I am saying. Okay, so 3 to 7 micrograms of the vitamin B12 is excreted in bile every day, but most of it gets reabsorbed in the enterohepatic circulation. Okay, so excess amount of administered vitamin B12, it remains free and it does not bound to the transcobalamin. What is transcobalamin? It is plasma globulin, and thus it gets excreted. Okay, so you should correlate this sentence with the earlier one. The transcobalamin, it actually helps vitamin B12 to remain in the body. The free form of it, it is excreted through the urine. Since the hydroxycobalamin is more protein bound, it is better retained than the cyanocobalamin. Okay. So next, the therapeutic uses in case of the pernicious, that is Addisonian anemia. So the treatment may continue through the whole life. Then we have the malabsorption syndrome. Malabsorption is abnormality of absorption. So the deficiency of vitamin B12 and the folic acid, it occurs with the coeliac diseases like in case of sprue, then idiopathic steatorrhea. Steatorrhea is excretion of fats into the fecal material. Okay, and these conditions in later stages, it results to the megaloblastic anemia. Okay, then we have the neurological condition. The high doses, that is 1 milligram or more of the vitamin B12, they are given to the patients of trigeminal neuralgia. Then toxic diabetic or alcoholic neuritis, or and the other nutritional neuropathies. Okay, so the high doses of vitamin B12, they are used in neuroblastoma in children. Okay, so neuroblastoma, it is a type of tumor that happens in children. So we have psychiatric disorders into which we can use the vitamin B12, and it is an old age disorder which may favorably respond to the vitamin B12 therapy. Okay, so next and the last slide of this is the preparation and dosage. So it is available as tablets, syrups, injectables along with other vitamins. Cyanocobalamin injection, they are available as red colored aqueous solutions of various concentrations. They are given through the intramuscular or the subcutaneous route. However, some patients show reduction in plasma concentration of vitamin B12 within 30 days of injection, and the development of antibodies against transcobalamin vitamin B12 complex is also seen. Therefore, hydroxycobalamin is not suggested. Okay, why hydroxycobalamin is not suggested? Answer to this lies in the earlier slide, where we have seen the hydroxycobalamin is more protein bound as compared to the cyanocobalamin. Okay, so it means that the hydroxycobalamin has more affinity towards the particular transcobalamin, which is a plasma globulin. Thus there are chances of production of antibodies against it. So to avoid this antibody production, the most common form of this cobalamin that we use is the cyanocobalamin. Okay, hydroxycobalamin is not suggested. Okay, so that was all for the topic, that is hematinics. In next lecture we will start with the coagulants and the anticoagulants. Okay, so before we actually learn about that particular chapter, it is my kind request to you all that please go through the that coagulation process, how blood coagulates. Okay, what causes its coagulation, so it will help you to understand more clearly about the drugs which are affecting this coagulation process. Okay, so that was all from my side, and this, thank you.